everyone to our virtual discussion for today that will discuss Allergies 101, facts and myths on food allergies and must know about allergic rhinitis. So to avoid distractions during the lecture, kindly follow these instructions. Please keep your microphones on mute and your video cameras turned off to avoid distractions. And if you have any questions, send to us by typing in our chat box. We will address your questions later during our Q&A session. If you are watching via Facebook Live, kindly send your questions through the comment section of the video stream. Please be advised that we will also record this lecture as reference for future learning sessions. So let me introduce our speaker for today. So she graduated Doctor of Medicine at Pamantasan ng Lungsod ng Maynila. She is a fellow of the Philippine College of Physicians, a diplomate of the Philippine Society of Allergy, Asthma, and Immunology. She had her fellowship at Philippine General Hospital and her residency at Hospital ng Maynila Medical Center. So let us all welcome Dr. Phorenice Francisco, our internist in Allergology and Immunology. Good morning, Doc.
Hello, good morning.
Hi, Doc, good morning. So I'm Shane Carianes, by the way. I will be your moderator for today. So, Doc, you may now share your screen.
Okay. Let me just share my screen. Can you see my slides?
Yes, Doc.
Okay, let me start. Good morning, I'm Dr. Phorenice Francisco, an allergist internist from QualiMed San Jose. Today I'll be discussing the facts and myths on food allergies and the must know about allergic rhinitis. I have nothing to disclose. These are my objectives for this morning's lecture. This is the outline. I will just give a short overview on allergies and discuss the topic March. Then we'll proceed on the discussion of food allergies. And for the second part, I will discuss the diagnosis and management of allergic rhinitis. So what is allergy? Allergy is the term most commonly used to describe clinical and pathologic manifestations which consist of vascular and smooth muscle reactions that develop rapidly after repeated exposure to the allergen and a delayed late phase inflammatory reaction. So allergy encompasses an immediate and a late phase inflammatory reaction from an allergen exposure. So this figure emphasizes the sequence of events in immediate hypersensitivity reactions or allergies. Immediate hypersensitivity diseases such as food allergy and allergic rhinitis are initiated by the introduction of an allergen, which can be a food or an airborne allergen. It stimulates a specific immune cell, the interleukin-4 producing T follicular helper cell, and also the production of the antibody IgE. The IgE sensitizes mast cells by binding to a specific receptor of your mast cell, which is your Fc epsilon R1 alpha, and this starts the sensitization process. And repeat exposure to the allergen activates the mast cells to secrete the important mediators such as your histamine, leukotrienes, and your cytokines, which are responsible for the pathologic reactions of immediate hypersensitivity. Is allergy a common disease? The answer is yes. According to the WHO, allergic diseases such as atopic dermatitis, respiratory allergies, and food allergies are now classified as the fourth most common global disease, and it affects at least 20% of all individuals in the United States and Europe, and its prevalence is increasing worldwide. What are the risk factors The development of allergies is the result of complex and poorly understood gene-environment interactions. There is a genetic predisposition for the development of allergies, and relatives of allergic individuals are more likely to have allergies than unrelated people, even when they do not share environment. Various environmental factors besides the exposure to allergens, including air pollution and exposure to microbes, have a profound influence on the propensity to develop allergies. So this is a very important concept. So what is atopic march? The term allergic or atopic march refers to the natural history of atopic manifestations, which is characterized by a typical sequence of IgE antibody responses and clinical symptoms which may appear early in life, persist over years or decades, and often repeat spontaneously with age. It is based on the observation that many infants with eczema or atopic dermatitis in early life go on to develop other allergic diseases in later childhood. Eczema or atopic dermatitis is usually the first, as shown here in the dotted green line, the first manifestation of the atopic march and may coincide with the food allergy, then followed by your asthma, and at the end of your spectrum is your allergic rhinitis. During the course of progression, some diseases persist while some subside. In general, atopic dermatitis predates other diseases, suggesting that it is the entry point for subsequent allergic rhinitis and asthma development. Today, our discussion will only focus on two allergic diseases, the food allergy and allergic rhinitis. With this introduction, we will now proceed with the first part of our discussion, the facts and myths on food allergies. The succeeding slides will discuss the 9 most common myths about food allergy. The first myth, adult onset food allergies are uncommon. So based on research, 1 in 4 adults with food allergy experience onset of food allergy after 18 years of age. In the Philippines, shellfish is the most common food allergen in adults, and most of my adult patients have specifically have shrimp and crab allergies. The next myth, food allergies in children remain lifelong. So, according to a local study, a person can outgrow certain food allergies such as milk, egg, wheat, and soy, while allergies to fish, shellfish, peanut, and tree nuts may remain lifelong. So, allergies to milk may spontaneously resolve within 2 years, while majority of patients with egg allergies may have spontaneous resolution within 3 to 4 years. Next, all reactions to food are due to allergies. This is false. Adverse food reactions can also be attributed to food intolerance, which is defined as an abnormal physiologic response to certain food, causing lactose intolerance, monosodium glutamate reactions, and food poisoning. Food intolerance may present with the following symptoms such as diarrhea, headache, fatigue, and abdominal pain. Next, severe reaction to food can occur through skin contact to food protein. This is false. Ingestion of allergen rather than casual exposure to the skin or close proximity to an allergen is almost the only route for triggering severe allergic or anaphylactic reaction. So I've mentioned anaphylaxis. This is very important among allergists. Anaphylaxis is the most severe clinical presentation of acute systemic allergic reactions, and the diagnosis of anaphylaxis is high likely when any one of the following two criteria is fulfilled. The first one is there is acute onset of an illness within minutes to several hours with involvement of the skin, mucosal tissue, or both, causing generalized urticaria, pruritus, or flushing, and swollen lips, tongue, and uvula, resulting to respiratory compromise, a decrease in blood pressure, and also severe gastrointestinal symptoms. The second criterion is there is an acute onset of hypotension or bronchospasm or laryngeal involvement after exposure to a known or highly probable allergen within minutes to several hours, even in the absence of typical skin involvement. So there are some patients that would only present with hypotension or difficulty breathing or desaturation without accompanying rash. So in these cases, we can diagnose them as having anaphylaxis. This is a common misconception. A spoonful of table sugar can be used to cure food allergies. So food avoidance and carefully reading the labels of food products are key strategies in the management of food allergies. So this is an example of a food label emphasizing the presence of an allergen. In this case, this is a tree nut, the cashew. In the case of food-induced anaphylaxis, intramuscular epinephrine is the recommended first-line treatment. So this is an image of the proper administration of epinephrine, which is given at 0.01 milligram per kilogram. A maximum dose of 0.3 milligrams is given among the pediatric group. Among adults, the maximum dose is 0.5 milligrams, administered intramuscularly at the mid anterolateral thigh. So you can give a maximum dose of 3 doses Q5 to 15 minutes. Chicken is one of the most common food allergens. So this is another common misconception. In order of prevalence, the big 8 most common food allergens are your milk, your egg, your peanut, your tree nuts, crustacean shellfish, fish, wheat, and soy. So chicken allergies to chicken are not that really common. Patients with seafood allergy are at increased risk of reaction to radiocontrast media. So based on studies, there is no documented relationship between non-IgE mediated hypersensitivity reactions such as anaphylaxis to radiocontrast media and allergy to crustacean shellfish, fish, or iodine. Therefore, patients with a history of seafood allergy are not at elevated risk for anaphylaxis from iodinated contrast media. The causes of reaction to radiocontrast media are due to its physiochemical properties or due to its hyperosmolarity. So in patients with adverse drug reaction to radiocontrast media, we usually advise them to give an isosmolar or hyposmolar agent instead. On the other hand, tropomyosin, a fish equivalent to the muscle protein, is the antigen responsible for allergic reactions to the seafood. Individuals with food allergies are contraindicated to receive COVID-19 vaccine. So we all know this is false. Severe allergic reaction or anaphylaxis or non-anaphylactic reactions to food are not a contraindication in receiving COVID-19 vaccine. The only contraindication in receiving a specific COVID-19 vaccine is a history of immediate allergic reaction, which is usually within 6 hours of any severity, such as urticaria with or without angioedema or anaphylaxis to a component of COVID-19 vaccine. So in the case of an mRNA vaccine, such as Pfizer, Moderna, you may be allergic to the polyethyl glycol or PEG component, or polysorbate in the case of Janssen and AstraZeneca, and or aluminum hydroxide in Sinovac or Sinopharm. Lastly, flu vaccination is contraindicated among patients with egg allergy. So this is a common misconception. Administration of flu vaccine to children with egg allergy is safe in children that do not manifest severe reactions after egg intake and in children who tolerate cooked egg. Most flu vaccines contain only small amounts of egg proteins which are introduced during the vaccine manufacturing process. However, the CDC now advises that even people with egg allergies should receive the flu vaccine because the risk of a severe allergic reaction is so small. Only an estimated 1.31 vaccinations in every million has been documented. This is the last myth. So we will now proceed with the second part of our discussion, the must know about allergic rhinitis. So what is allergic rhinitis? Allergic rhinitis is a symptomatic disorder of the nose induced after allergen exposure by an IgE-mediated inflammation of the membranes lining the nose. The diagnosis of rhinitis is suggested by the presence of one or more of the following symptoms: the presence of nasal congestion, anterior and posterior rhinorrhea or the postnasal drip, sneezing, and itching. Rhinitis can be classified by pathogenic mechanism as allergic or non-allergic rhinitis, but for this discussion, we will only focus on allergic rhinitis. But important to note, the most common forms of your non-allergic rhinitis are your infectious, vasomotor rhinitis, and your NARES, and the less common forms of your non-allergic rhinitis are the following. The disease currently affects between 10% to 30% of the population, and studies indicate that prevalence rates are increasing worldwide. And important to note is that allergic rhinitis is notably present in about 75 to 80% of all patients with asthma and in nearly 100% with allergic asthma. So it's really common. And now we'll proceed with the classification of your allergic rhinitis based on severity, which are as follows. Mild rhinitis severity is present when symptoms are not interfering with the quality of life, such as impairment of daily activities, work or school performance, leisure activities, and sleep. On the other hand, moderate to severe rhinitis is present when symptoms are troublesome or there is negative impact on any of these quality of life parameters that I've mentioned a while ago. Symptom frequency has been divided by some into intermittent, wherein symptoms can occur for less than 4 days per week or less than 4 consecutive weeks per year, or it can be persistent when nasal symptoms occur for more than or 2 to 4 days per week or more than equal to 4 consecutive weeks per year. Now, let's move on to the diagnosis of allergic rhinitis. The most important single element for establishing the diagnosis of rhinitis, it can be either allergic or non-allergic, and differentiating it from other conditions with overlapping symptoms is the clinical history. The age of onset, the duration, frequency, severity, and timing during the year, suspected triggers, pattern of presentation, and progression of each patient's specific symptom should be obtained and recorded. The history should also include the success or failure of past therapeutic interventions, including self-prescribed, over-the-counter medications, or physician-prescribed treatments. The family history and personal history of comorbid respiratory conditions such as exposures in the home or workplace should be included in the patient history as well. While the history has greater reliability and predictive value than solely relying on the physical exam, the combination of history and physical exam is still advised. For a patient with rhinitis symptoms, a physical exam should be completed that encompasses not only the upper airway but also the lower airway, the eyes, the ears, and skin to identify findings that may suggest the presence of a comorbid allergic or non-allergic condition. These comorbid conditions may include accompanying allergic conjunctivitis, otitis, dysphagic tube dysfunction, chronic rhinosinusitis with or without nasal polyps, asthma, and atopic dermatitis. Also, documentation of normal findings, such as the absence of septal perforation, is important to establish in the baseline exam findings prior to the prescribing of medications, specifically of your intranasal corticosteroid, which might lead to adverse events. While specific nasal and oropharyngeal physical exam findings, such as your allergic shiners, your pale and boggy nasal mucosa, your pharyngeal hyperplasia or cobblestoning, may support the diagnosis of allergic rhinitis. There are no pathognomonic findings that distinguish allergic versus non-allergic versus infectious rhinitis. So history is very important in this case. Common conditions that may mimic rhinitis are as follows: cystic fibrosis, which is common in the pediatric youth, ciliary dyskinesia, presence of nasal foreign body, anatomic abnormalities such as nasal septal deviation, nasal valve prolapse, cerebral spinal fluid leak, and the presence of nasal sinus tumor should be investigated or should be ruled out. Now let's discuss the common diagnostic tests used to support the diagnosis of allergic rhinitis. So, diagnosing rhinitis may be possible by, as I've mentioned a while ago, by combining the patient's history and physical findings. However, in most cases, laboratory and or skin tests will confirm the diagnosis. Based on Allergic Rhinitis 2020 practice parameter, air allergen skin prick testing or serum-specific IgE testing for air allergen are recommended to confirm the diagnosis of allergic rhinitis in a patient with a history consistent with allergic rhinitis. So this figure shows how to perform the skin prick test. So you have an allergen extract. This allergen extract will be placed on the volar aspect of your forearm, and then it's just administered. The extract is just administered at the intracutaneous layer of the skin. And after 15 to 20 minutes, we will observe for any positive or negative reaction. A positive reaction will look like this one. So a positive reaction will either have an induration of more than or equal to 3 millimeters, or a reflex erythema of moderate equal to 10 millimeters. So a patient may have a mono or polysensitization to different aero allergens. In some cases, serum-specific IgE to aero allergens is requested if skin prick test can't be done due to prior intake of antihistamine. Usually, antihistamine is withhold for a week prior to skin testing. But in serum-specific IgE, there is no need to withhold your antihistamine. So this is a sample of a result of your multiplex serum-specific IgE to aero allergen. This is ALEX2 test. The value is high if the level of your IgE is between 5 to 15 and very high if it's more than 15. So most of the available multiplex serum-specific IgE are uh, are a combination of your food allergen and aero allergen, and it consists of uh, multitude of allergens, a total of 295 allergens. In contrast with your skin test, we only test for approximately 50 allergens. Now we'll move on to the management of allergic rhinitis, which encompasses allergen avoidance, pharmacotherapy, immunotherapy, and patient education. First, let's discuss allergen avoidance. This is a summary of specific control interventions for the most important allergens, your house dust mite, your cat and dog dander, your cockroach, your inner moles, and your pollens. In patients with allergic rhinitis triggered by the exposure to indoor allergens, the avoidance is the first intervention to prevent the appearance or the worsening of nasal and eventual bronchial symptoms. Important to note here is that the use of HEPA air filter is recommended in the reduction of most of the inhalant allergens, specifically in the control of your house dust mite, your cat and dog dander, and your pollen. For the pharmacotherapy, assessment of allergic rhinitis severity through the use of validated instruments such as your visual analog scale or VAS can guide treatment and monitor the degree of disease control. The VAS score of less than 5 was classified as having mild allergic rhinitis, while a score of more than or equal to 5 has been used to represent moderate to severe allergic rhinitis. So this is just subjective. I've mentioned this since the VAS score is used to guide physicians in giving specific treatment to their allergic rhinitis patients. So, sorry for the busy slide. This is just an algorithm for intermittent allergic rhinitis. I will just mention the most important points here. For mild intermittent allergic rhinitis, the first line treatment is monotherapy with an oral second generation antihistamine or an intranasal antihistamine. For moderate severe intermittent allergic rhinitis, the first line is still monotherapy with an oral second generation antihistamine or intranasal antihistamine. And the second line is the treatment with the intranasal corticosteroid. On the other hand, this is an algorithm for the persistent allergic rhinitis. For mild allergic rhinitis, for the persistent allergic rhinitis, the first line treatment is your intranasal corticosteroids While for the moderate, severe, persistent allergic rhinitis, the first-line treatment is a combination of intranasal antihistamine and intranasal corticosteroid. And the second line is your intranasal corticosteroid monotherapy. Important to note here is that there is no recommendation that can be made for or against the use of combination intranasal corticosteroid and second generation oral antihistamine among patients who failed to respond with the initial therapy. Also, intranasal corticosteroid is preferred over leukotrienes or Montelukast due to frequent neuropsychiatric symptoms associated with leukotriene use. So, based on the current guidelines, leukotriene antagonist use is no longer recommended among patients with allergic rhinitis due to its debilitating neuropsychiatric side effects. So, if you will ask if there is an available intranasal antihistamine in the Philippines, there is one, but in combination with your intranasal corticosteroid. This is a combination olopatadine plus mometasone furoate nasal spray. This is available in the market. One of the options for therapeutic intervention among allergic rhinitis patients is allergen-specific immunotherapy. This is the practice of administering gradually increasing quantities of an allergen extract to an allergic subject to ameliorate the symptoms associated with the subsequent exposure to the causative allergen. The important caveat here is that you have to identify first the aero allergen triggers through skin test or serum specific IgE test before you can offer allergen immunotherapy. There are two types of immunotherapy, the subcutaneous immunotherapy as shown in this figure, and the sublingual immunotherapy, which do not require updosing. The only available sublingual immunotherapy in the Philippines is for the house dust mite, the Antihistamines. So the treatment duration in allergen-specific immunotherapy is usually between 3 to 5 years. So this is patients will really undergo a prolonged treatment. So the goal of immunotherapy is to attain immune tolerance to allergen in which the allergic patients are sensitized to. The following are the indications for subcutaneous immunotherapy. So in summary, allergen-specific immunotherapy is indicated if response to primary therapy is poor, if compliance with pharmacotherapy is low, or if complications such as asthma are present. Excuse me. Lastly, we can never underscore the importance of patient education. Education of the patient and or the patient's caregiver on the management of rhinitis is essential. Such education is likely to maximize compliance and optimize treatment outcomes. Patient information as well as the communication and partnership of treating healthcare professional and the patient appears to be of importance. So in summary, we discussed general concepts regarding allergy, its prevalence, factors, and clinical manifestations. We also identified and addressed common misconceptions regarding food allergies and discussed the diagnosis and management of allergic rhinitis. These are my references. Thank you. So do you have any questions?
Thank you, Dr. Francisco, for the very fruitful discussion. So let us now proceed to our question and answer. Actually, we received some questions here. So let me read some. So first question po, Doc. Are allergies of the skin stress-related?
There are some cases, um, it depends, but specific allergic skin conditions such as atopic dermatitis and urticaria can be triggered by stress. So, one of the most common manifestations of a stress-related skin manifestation is pruritus or itchiness. So, yes.
So yes, yes, allergies are yes, stress related. So thank you for that, Doc. Next question, malaki po ba ang chance na kapag may pangangati ng balat, allergy na po iyon kaagad?
Hindi naman po kasi ang importante po nating malaman, pag nangati po yung balat, hindi po agad ito isang parang allergic manifestation. Kailangan pong malaman sa ano po yung pinanggagalingan ng pangangati ng balat. So, depende po dun sa edad, tsaka depende po dun sa kondisyon ng balat. Pag yung pasyente po ay mataas yung risk or mataas yung parang the patient has a strong family history of atopy or may other allergic conditions such as allergic rhinitis and asthma, we can parang correlate yung pangangati niya sa isang allergic condition. Pero kung wala yung mga yun sa nabanggit, maaaring iba yung pinagmulan nun. Usually kasi yung cirrhosis or severe dryness of skin can cause intense pruritus or itchiness ng balat. So, depende din sa temperature or climate. Pag masyadong mainit o masyadong malamig, ano na pag ngayon, tag-ulan, malamig, pwede mag-dry yung skin. So, yun, prone sa pangangati ng balat.
Okay, so moving forward, Doc, with the next question. Is it true na may chance na mawala ang allergy kapag mas ina-expose sa nagkukos ng allergy?
This is not really entirely true. Kasi we should first, kasi di ba may concept, I've mentioned dun sa discussion ko yung immunotherapy, yung reintroduction of the allergen that causes your sensitization or yung mga allergic symptoms nyo. Pero you have to first or confirm or identify your specific trigger. So, mahirap sabihin na dapat lagi kang magpapa-expose dun sa allergen kung saan ka allergic para ma-obtain yung tinatawag na tolerance, which is not entirely true. So, dapat kasi ma-confirm muna natin kung yung allergen na yan, yung talagang nakakapag-cause ng allergies mo. Ang mangyayari niyan, magkakaroon ng unnecessary allergen avoidance. Pag we confirm it through skin test or oral food challenge test na hindi naman pala ito yung nakakapag-cause ng allergy mo.
Okay, and medyo delikado yun, Doc, no? If in the event na continuous yung exposure dun sa allergy.
Kaya I'm really not really supporting that notion. Kasi, yun, buti na lang din you've mentioned that. Kasi if you reintroduce a specific allergen na sensitized ka pala, patient may develop mild symptoms such as urticaria or yung pinaka-severe allergic manifestation, which is anaphylaxis. So yung anaphylaxis kasi is a life-threatening allergic reaction or manifestation. So yun yung iniiwasan natin. So we're not really supporting that.
Okay, thank you, Doc. Next question po, is it okay or safe to take antihistamines right away if you have an itchy skin or allergic rhinitis attack, even without a doctor's prescription?
I will not really support that. It's very important that you consult your physician to confirm the diagnosis of allergic rhinitis. So as I mentioned a while ago, allergic rhinitis is confirmed through a comprehensive history and physical examination with the support of your um, laboratory tests such as your serum-specific IgE and through the serum-specific IgE test. So, through skin test. So, I advise these patients na to refrain from taking yung mga over-the-counter antihistamines. It's very important that you consult your doctor. Lalo na, di ba, I've shown the algorithm in patients with persistent symptoms, with severe symptoms, oral antihistamine, second generation oral antihistamine monotherapy will not suffice. So, kakailanganin niya ng other medication to address the symptoms.
Okay, thank you, Doc. Next question po, Doc, isa bang COVID symptom ang allergic rhinitis? Kasi minsan, di ko na alam kung allergic rhinitis pa ba or may COVID symptoms na ako.
Encounter ako ng maraming ganitong patients. Pero, importanteng malaman na magkaiba yung sintomas ng allergic rhinitis sa flu-like symptoms ng COVID. Pag sa allergic rhinitis, yung mga nabanggit ko, may mga nasal congestion, rhinorrhea o pagsisipon, sneezing, pangangati ng ilong. Pero sa flu-like COVID symptoms, usually, ito ay associated with fever and also with anosmia o pagkawala ng pang-amoy o ng dyschezia o pagkawala ng panlasa. Kung mga ito ay kasama ng flu-like symptoms mo, o kaya meron kang history of exposure to a known COVID patient, so malamang sa malamang ito ay isang sintomas ng COVID-19.
Okay. Ayan. Thank you, Doc. So, in short, cluster of symptoms kasi, or signs and symptoms ang COVID-19. Yeah, it's not limited to allergic rhinitis.
Yeah.
So, yeah. So, thank you, Doc. Next question. Ito, Doc, medyo lengthy lang po siya, no? But let me read it. Hello, Doc. I am currently suffering from a condition that causes hives and rashes sa skin ko. Even though I believe na iniiwasan ko naman lahat ng food allergies ko. I was initially given bilastine to take for 2 weeks. It is effective at first, but kapag makakalimutan ko and even after that 2-week course of medications, nagsisimula na naman akong mangate. This includes areas around my mouth, under my eyes, and mostly sa leeg and other parts of the body. What to do, Doc? Sa sobrang takot ko, ginawa kong maintenance yung bilastine. Please help. Thank you.
Okay. Sa case mo, kailangan magpa-consult ka ng isang allergist to confirm ano yung trigger. On your case, matagal na siya, no? So, you are diagnosed with chronic urticaria. So, with chronic urticaria, there are a lot of causes of chronic urticaria. So you have to rule out, yun may nabanggit ka, a food allergen and also an aero allergen cause. And also aside from that, you have to rule out the physical causes of urticaria. Yung physical causes, yung ibig sabihin, exposure to a change in temperature in the case of cholinergic urticaria, and exposure to increased pressure or exposure to parang a slight stroke in the skin, yung tinatawag na dermatographism. So these are examples of your physical urticaria. And aside from that, you have to rule out infectious cause of your chronic urticaria. And other than that, you have to also rule out metabolic if you have thyroid disorder. And other than that, you have to rule out autoimmune cause. And the most common autoimmune cause of urticaria is autoimmune thyroiditis. So there are a lot of causes of chronic urticaria. So we have to pinpoint, investigate, confirm the triggers para we can manage it properly. With regards to your question regarding Benlysine, so there's no problem with taking Benlysine a prolonged period of time. Pero yun nga, we have ang pinaka-important kasi with the management of chronic urticaria, you have to identify the trigger. Kung di, talaga magpapatuloy yung mga simptomas ng pamumula, pangangati, kahit na nagtitake ka ng antihistamine. So, if you identify the trigger, ma-address natin, mabibigyan ka ng instructions on how to prevent, decrease your exposure, so we can control your symptoms. And in the case of chronic urticaria, kasi it may persist for about 2 to 4 years. So, majority of the cases, they spontaneously resolve after 4 years. Some may persist. So, ayun. So, cases of autoimmune urticaria yung nagpa-persist ng matagal. Ayun lang.
Okay, thank you, Doc. Next question, meron po bang home remedies na pwedeng gawin if in case inatake ang isang tao ng skin allergy?
Depende kasi kung anong skin allergy ito. Kung ito po ba ay skin allergy from atopic dermatitis. Kasi kung atopic dermatitis, you have to have depende kasi kung anong severity niya. If it's mild or severe atopic dermatitis, you have to have treatment with topical steroids or support with the sedating antihistamine. In the case of urticaria or hives, usually you really have to consult your physician to identify the trigger if it's urticaria. Kasi kahit na mag-home remedy ka, magpe-persist siya, magtatagal yung symptoms hanggat hindi mo na-address or hindi mo na-identify yung trigger. So the bottom line is consult your physician and not just rely on home remedies. Ayun.
Okay. Next question, Doc, as we move forward. Hello po, Doktora. Question lang po, pwede po bang magkaroon bigla ng allergy sa gamot na dati mo pa namang iniinom?
Pwede po. Kung nagbago po kayo ng, depende po kung anong gamot po ito Pero kung nagbago po kayo ng brand, so ito po mga gamot po kasi natin may tinatawag silang mga excipient o mga preservative or ingredients na pwede magkaiba sa ibang brand. So if yung dati, hindi ka naman nagkakaroon ng reaction. For example, with paracetamol, hindi ka nagkakaroon ng reaction with the usual. Tapos, nag-iba ka ng brand. Usually, we tag this patient as having an adverse drug reaction to this specific drug, paracetamol, due to an excipient cause or ingredient. So, pwede siya.
All right. Next question, Doc. Can you comment on dust allergic rhinitis and bronchial hyperresponsiveness? I think they are asking about the difference of the two, Doc.
Bronchial hyperresponsiveness. This is entirely different disease entity. So, yung nasal symptoms are common in allergic rhinitis, and bronchial hyperresponsiveness is a clinical manifestation of your bronchial asthma. Pero as I've mentioned a while ago, 75 to 80% of patients with asthma have allergic rhinitis, and 40% of patients with allergic rhinitis have asthma. So they are interrelated. So this interrelation is what we call one airway, one disease. This is an entirely different disease entity pero magkadugtong sila. So So, ang tawag namin dyan, one airway, one disease. So, we treat allergic rhinitis to prevent asthma attacks. We treat bronchial asthma with also while treating allergic rhinitis. Ayan.
All right, thank you, Doc. I think this is in relation to the home remedy that we tackled a while ago. Meron po bang ma-advise na home remedy? Yung allergic rhinitis kapag super clogged and minsan naman po nag-runny nose. Pabalik-balik na po kasi yung situation.
Symptoms. So, kailangan po nating imbestigahan, kumpirmahin kung ito ba ay allergic rhinitis, allergic rhinitis, base po dun sa history nyo at examination ng ilong. So, usually kasi hindi nagre-responde yung mga usual remedies na binibigay natin, di ba? Usually kasi nag-aano ng mga asin na may tubig. Ito ay supportive lang. Pero ang pinaka magandang gamot, lalo na kung laging barado ang ilong, ay yung tinatawag na intranasal corticosteroid na piniprescribe o binibigay ng iyong doktor. So, if ever persistent na siya, I advise you to consult your physician.
All right, thank you, Doc. Okay, so far, Doc, that was the questions. Ayan. So, thank you very much, Doc, for the very wonderful discussion and interactive discussion. So, on behalf of QualiMed San Jose del Monte, we would like to award their Certificate of Appreciation to Dr. Phorenice Francisco for her expertise and valuable role as our resource speaker during the webinar entitled Health Talk at Your Fingertips, the QualiMed Hospital San Jose del Monte online lecture series, Allergies 101, Facts and Myths on Food Allergies and Must Know About Allergic Rhinitis, given on the 22nd day of, let me correct this date, given today, 18th of July 2022 via Zoom virtual event. And this is signed by Dr. Angel A. De La Razabal, our medical director. So before anything else, I'd also like to acknowledge the presence of our QualiMed physicians and also the personnel and physicians of the City Health Office. Thank you very much for attending our sessions for today. So for further questions, just in case medyo nabitin tayo sa Q&A portion natin with Dr. Francisco, ayan. So you can visit her clinic as shown on your screen. So she's here at QualiMed San Jose del Monte every Wednesday, Friday, and Saturday. Every Wednesday at 1 p.m. to 3 p.m. and Friday and Saturday from 9 a.m. to 12 noon. Or you may also contact the following numbers at 044-307-0000, local 201. That is the Internal Medicine Clinic. So thank you, Doc. And also, let me announce some promos and initiatives from QualiMed San Jose del Monte. So we have our ongoing ancillary promo. So consult with our cardiologist. So we have our Healthy Heart packages as seen on your screen. So we have a Healthy Heart all-year package 1 at 8,330 pesos. That is inclusive of arterial and venous duplex scans. And also we have a Healthy Heart all-year package 2 that's amounting to 3,320 pesos. That is inclusive of 12-lead ECG and 2D echo. And also our Healthy Heart limited time package, which is at 3,771. That is inclusive of 12-lead ECG, 2D echo, and chest x-ray. Also, wag nating tiisin ng sakit ng ating katawan. So of course, consult with our rehabilitation department and avail any of our 5+1 PT packages as seen on your screen. This promo will run from February 1 to December 31 of this year. You may also inquire on the number shown on your screen. That's the 044-307-0000, local 109. Also, I'd like to use this opportunity to promote our QualiMed Access Card, our Kalusugan Caravan 123. So you may join our health clubs now. That's inclusive of our diabetic, hypertension, and geriatric benefits. So you may buy a one QualiMed Access Card for 2 members and join any of the 3 following health clubs. You may also contact Room 212, that's our IOH department at 0917-866-2774. And also our multi-specialty centers. So we have our Diabetes and Hypertension Center. It is now open at Room 212. You may consult our clinic from Monday to Friday, 8 a.m. to 5 p.m. So we have our diabetic clinic service packages and hypertension clinic service packages as seen on your screen. We also have our Women's Health Center. It's now open at room 203. So the clinic schedule is from Monday to Sunday from 8 a.m. to 7 p.m. And of course, we also have our breast center services in line with our Women's Health Center. So you may also call our local lines as seen on your screen. So that's local 203 for the Women's Health Center. Also, we have our eye aesthetic center services. So for those who are aiming to be more confident with your skin and your with your everyday routine, so you may also visit our eye aesthetic center at room or at local 405 at 2nd floor. And also our eye center and our geriatric center, which is inclusive of geriatric care club program, geriatric assessment, and scientific symposiums and online health lecture series. So please do like and follow our official Facebook page at QualiMed Hospital SJDM. So you may like our FB page for further updates and announcements. So thank you very much. And again, thank you to Dr. Phorenice Francisco for the very lively and interactive discussion for today. So thank you, Doc.